Hello, this is Dr. Mukesh Varma. Let us talk about tuberculosis. And in this, let us talk about who are at risk for tuberculosis and people who are already infected with HIV infection and who had a prior history of TB treatment and who had TB exposure with their family or their friends' contact, and the people who had a travel history to an endemic area where TB is widely spread, and for the homeless people and who are shelter dwelling people and who are at risk of immunosuppression. These are the primary category of the people who are at risk for tuberculosis infection. So this category of people should be at highly conscious situation to avoid tuberculosis infection. And in tuberculosis, we have multiple types of tuberculosis. In this, we can simply categorize them into two categories. The first one is pulmonary TB and the second one is extrapulmonary TB. And pulmonary tuberculosis might be asymptomatic and discovered incidentally on chest radiography. And there are some classical clinical features which are associated with active pulmonary TB. That is, the first one is cough, which might be milder earlier in the disease, but it might be very severe later with bronchial involvement, and weight loss, fever, night sweats, hemoptysis, and chest pain due to pleural involvement, fatigue, and chills. And let us talk about the elderly patients who are infected with TB. They might not display typical signs and symptoms of TB infection because they might not have a good immune response to the bacterial infection in the body. Active TB infection in this age group may manifest as non-resolving pneumonitis. So we have to rule out pneumonitis to diagnose TB in elderly patients. And on physical examination, we can see fullness with decreased fremitus and post-tussive rales, and bronchophony, that is bronchial breath sounds in lung parenchyma, and also tubercular breath sounds which are very high-pitched bronchial breathing, and amphora, that is distant hollow breath sounds heard over cavities. And the second one is radiography, and the radiography says that chest X-ray might be unremarkable in up to 60% of seronegative PL-HIV and 22% of HIV seropositive persons with pulmonary TB. And a chest X-ray is the cornerstone of diagnosis and monitoring of tuberculosis disease in the majority of the population. And in the chest X-ray, we will see a patchy or nodular infiltrate. Frequently, it is seen in apical or subapical posterior areas of the upper lobe or superior segments of the lower lobe. And we can also see cavity formations also, which is more apparent with CT or MR imaging. And air fluid levels are more commonly seen in lower lobe cavities. And also fibrotic scars can be seen with sharp margins. Lower lobe TB findings are non-specific and include poorly resolving pneumonia, atelectasis, mass lesions, and cavities, and pneumonia with hilar lymphadenopathy as indicative of primary TB. And apart from the laboratory findings, we will be seeing normocytic normochromic anemia, hypoalbuminemia, and hypergamma globulinemia, low white blood cell count and CD4 count in PL-HIV, and monocytosis.